Okay.
Yes. So there are two cases, sir. First case,
Yeah.
a 21 years
Yeah.
male with a history of RTA, 1.5 day back. The mode of RTA was he fell on the road while climbing in the bus and was dragged by the bus wheel. Patient initially treated at a nearby hospital. Then he was shifted after a day to our hospital, sir.
Okay.
So he had sustained a blunt trauma to head, chest, abdomen, left thigh and leg, sir. History-wise, patient did not become unconscious and there was no ENT bleed. Patient has no medical comorbidities. There is a history of cerebral gliosis in the childhood, sir.
No, that is relevant, but not so relevant as far as trauma is concerned.
Yes, sir. Just it was only to see if there are any new changes in the CT or not, sir. Like there was some previous history, so there are some changes in the CT.
Okay.
Yes. On examination, patient was conscious, coherent, and cooperative. He was on 2 ml per hour noradrenaline when he was brought to ER. Other vitals were stable. Per abdomen, it was soft. There was tenderness in the right upper quadrant. Bowel sounds were absent. There was deep abrasion over the left chest region and left thigh region, and superficial abrasion over the left leg. Urine output was high colored.
How do you know? Was he catheterized already?
Yes, sir. He was already catheterized.
Okay.
He was treated in a hospital, so he came with the catheter and rail strip, sir.
Central line was there or?
No central line, sir.
So they were
Only
giving
catheter.
noradrenaline peripherally.
Peripherally, yes, sir.
Okay. Vinod.
Hello, sir.
Predominantly questions will be for you. Now,
yes,
this patient is, in front of you. What will you do? How will you assess him?
Sir, I'll do E-fast, sir, and then I'll proceed, sir.
What? You will?
E-fast, ultrasound.
No. Before that, what will you do?
I'll give the bolus of fluid, sir.
No, bolus of fluid and all is later. But what is primary survey? What are you going to do?
Yes, sir. Yes, sir. In the primary survey, I'll check for any active bleeding in the externally, and then I'll try to stop this blood vessels, and then.
No. See, I am not asking you theory, man. Now
Yes,
this
sir.
patient is there. What is that? She's already told you that he is stable. So
Yes, sir.
quickly, what are the things you are going to assess?
Yes, sir. I'll check for the spine and then abdomen, sir. Abdomen, if there is any tenderness. Hello.
No, you keep talking.
Yes, sir.
No.
I'll check for the.
No. See, what you have to say is, I will check if the airway is, normal. There is no secretions inside the mouth, and
Yes,
then breathing with, airway with cervical spine. So
yes, sir.
first thing is to make sure that is at the site of that. Okay, let us start differently. Let us say you've been called, or the ambulance from your hospital has been called
Yes,
to the site of the trauma.
yes,
So
sir.
what are the things you're going to assess, and what are the things you're going to ensure before you shift him to the nearest hospital?
Yes, sir. I'll check for airway, breathing, and circulation, sir.
Okay. Let
And
us say
then
there is bleeding. What will you do to stop the bleeding?
I'll give just a. I'll tie a corn or something to stop the bleeding, sir.
You'll tie a what?
Cloth, sir, whatever it is available now.
Okay, or whatever. As long as you stop the bleeding,
yes,
you
sir.
give him oxygen, and
yes,
then
sir.
you start a insert a cannula, preferably what
18,
cannulas?
18 to
18. Usually,
yes,
preferably 18 into the antecubital fossa,
yes, sir.
and start IV fluids.
Yes, sir.
Then check the vitals, give
Yes,
him
sir.
oxygen. And when you shift the patient from wherever, if he's fallen down or whatever, ensure that you protect the cervical spine. This is all you can do in the at the site.
Yes, sir.
So shift him gently without moving the cervical spine
Yes, sir.
onto the ambulance trolley, and then shift him carefully, protecting the cervical spine. Ensure that fluid is going into the thing, and you have controlled the bleeding as much as possible. So this is what you do at the site of the injury.
Sir, hello, sir.
Multiple trauma, what will you do?
Hello, sir. Sir, hello.
Ah,
Sir, sorry, sir. I'm getting call from emergency. Just a second. Hello.
you answer that. Somebody else, Nikita. Hello?
Yes, sir. If there are multiple traumas,
Ah,
if the patient is hemodynamically stable, the standard of investigation would be a whole body CT, sir.
no. See that you are at the site of the
Yes.
trauma. What will you do? Quickly prioritize. See the patient
sir.
who is extremely ill, and this one, if there are multiple ambulances, you quickly deal with that person.
Rage.
And the patient who is in shock and everything, you quickly do whatever is necessary to the patient. You have to, for example, if somebody is completely unresponsive and GCS of less than 8 and or GCS of 3 or so, then that patient will not get the priority, because the chances are the patient is going to die. So you have to then prioritize patients whom you can resuscitate and save. So what,
Yes.
though it is actually cruel to do it, but that is what you have to do. That is called triaging. So quick triage of the patients. You have to prioritize patients whom you can help, whom you can deal with very quickly. If patients is breathing and start give them oxygen, put a cannula in. If there is any ongoing major bleed, as if there is available blood pressure cuff or something, tie that around it and stop, raise the pressure and stop the bleeding. Or if you don't have that, any cloth or bandage or whatever, just tie the bandage and then shift the patient from the ambulance. You will obviously need to have multiple ambulances when there is major trauma. If there is one patient, then that patient's obviously you have to deal with him exactly the way Vinod described. So then the patient comes to the hospital. So you are the casualty medical officer. So what are the things you will do in the casualty? So, Nikita?
Yes, sir. Will
Quickly. Why are you wasting time? Quickly. Praveen, I'll ask Praveen. Praveen.
Sir, yes, sir.
Quickly.
Sir, we have to do the primary and secondary survey, sir. Primary survey
quickly,
includes
primary survey. What
yes,
is
sir. Primary survey
ABCD?
includes airway. In airway, we'll be checking the if airway is protected or not, and is cervical spine is protected or not. With color, we have to check it, and if patient is intubated or not, we have to check it, sir.
Yes.
If patient is intubated, we have to check the ET position and if it is working or not properly. And breathing, if patient is requiring oxygen or not, I have to check and we have to give oxygen
No. There is no
supplementation
question of
accordingly.
requiring oxygen or not. You have to give everybody
Yes,
oxygen.
sir. Yes,
So even before you intubate, you have to give them oxygen, stabilize the cervical spine. So that is why A is always airway with
First.
cervical spine. B
Yes,
is
sir.
breathing. C is circulation with
Circulation, sir.
control of the hemorrhage. C
Yes,
is
sir.
not just circulation with control of hemorrhage.
Yes,
And
sir.
D is
D is for disability, sir.
disabilities, and E is
And
for
E for exposure, sir.
exposure. So you have to
exposure.
proper exposure to see what are the trauma that is there, and you can then put a gown to the patient. And
Yes,
after
sir.
that, then depending on whether the patient is stable or unstable, you can do a quick fast to, if the abdomen is distended. In this patient, there was distension with tenderness on the left side, she said. Right side.
Right, sir.
Yes.
Right side. Okay. And also check for presence of, any pelvic fracture. And then if there is pelvic fracture or if there is blood in the external, penile sperm, you don't catheterize such patients. You can do a per rectal examination and see if there is any urethral injury before you catheterize. So this is very important. So before you if there is blood in the external penile meatus, you can't catheterize such patients because there is chance that there will be urethral injury, and so you are going to create a false track. So don't try to catheterize them. If you need urine output, you will have to do a suprapubic catheter in such people. Okay. So then a fast scan to assess the send the blood for grouping, saving and cross matching, quick hemoglobin and all that you need to do, but send the blood immediately for and if the patient is very unstable, you can even consider giving them O negative blood quickly, and then do a fast scan and check for the airway and see if there is any pneumothorax. If there is pneumothorax, you need to, what do you need to do?
ICD insertion,
ICD
sir.
insertion.
Yeah. If the patient has suggestions of tension pneumothorax, what will you do? Hello?
Yes. Water seal, sir.
No, quickly. Sania, tell them what you do.
So
Or,
we use
Sanjana?
a wide bore needle in the second intercostal space to relieve the tension as soon as possible
Correct.
first. If ICD is not available bedside.
Whichever side is a tension pneumothorax,
How do you suspect tension pneumothorax?
How do you suspect tension pneumothorax? Sania?
So first of all, the patient will be in shock. Vitals will not be stable.
Okay.
BP would be dropping, and also when you percuss, there'll be hyper resonant sound over the whichever side of the chest is there, and breath sounds over that side of the chest will be reduced. Patient will be in respiratory distress, using the muscle, having a difficulty in breathing, or will be breathless. Sir.
Sir.
And
Also saturation will not be maintaining. Saturation will not be maintaining.
What happens to the neck veins?
Jugular.
It is distended, sir.
Neck veins, trachea.
Trachea shifted to the other side.
Correct.
Yes.
So trachea, neck veins, as you said, all the other signs, patient will be tachypnic, dyspneic, and there will be air hunger, saturations will be dropping, and then there will be deviation of trachea, and the neck veins will be engorged. So you quickly relieve the tension pneumothorax, as you said, with the large bore cannula in the second intercostal space. So Nikita, tell us basic, how do you identify the second intercostal space?
Sir, from the sternal notch, we identify the clavicle, sir. Clavicle, it is generally above the second rib. So below that is the second intercostal space.
Okay. So once you've done that, then you have to you have to insert the intercostal drain also. So always when there is trauma, you will get an idea. There may be fractured ribs. So there can be subcutaneous emphysema. So that gives you another clue as to there is possibility of tension pneumothorax, or at least pneumothorax or hemopneumothorax. Now, once you insert the intercostal tube, Nikita, you will see a lot of blood. You'll see a lot of blood. What will you do then?
So, we should immediately connect it to a underwater seal or one-way
Correct.
wall, sir.
And then
Let all the
you have to measure the volume of blood. So you can even, if you have the facility for cell saver, you can run it into the cell saver so that you can then re-infuse this, blood back to the patient. If you don't have the facility of cell saver, you have to measure the volume. What are the volumes that you will be concerned about? Sanket? Are you there, Sanket?
Yes, sir.
What are the
Yeah.
volumes you'll be concerned about?
Sir, if it's continuously draining, if then we can either do intermittent clamping and arrange for adequate blood, and keep in mind of like patient may need for further exploration if this continuous.
No, there are figures, Sanket. Do you know the figures or not?
No, sir, I don't.
Tanya?
Over greater than 1 liter.
Who said that?
Sir, in general, massive hemothorax means it's greater than 1 to 1.5 liters, sir. So is that significant enough to
1.5
transfusion?
liters is considered. I think
Okay.
1 liter maybe, you need to start worrying. 1.5 liters is the volume. If you get 1.5 liters as soon as you insert the intercostal tube, or if there is ongoing bleeding at a rate of 200 milliliters per hour, then you need exploration. Sometimes you may want to get a quick CT thorax and abdomen, but if the patient is not stable, you have to take him to the OT to, because you may have a massive, so a thoracic surgeon needs to get involved. You may have, vascular injury in the thorax, and that needs to be sorted out immediately. So the volumes are 1.5 liters stat or 200 ml per hour in the intercostal tube. So that you need to watch continuously. It is not, sufficient if you put an intercostal tube. You need to watch the drainage, how much is collecting every hour. So that is extremely important. Okay. So
Yes, sir.
again, if the patient is stable, only then you will wheel them to the CT scan. If the patient is unstable, you will do a fast scan in the casualty to identify liver, spleen, and other solid organ injuries, pelvic, fracture pelvis. Is there retroperitoneal hematoma? All of these things you note. What if the patient is otherwise stable, but there is pelvic fracture and retroperitoneal hematoma? What will you do? Sanya?
So first of all, immobilization of the patient for the pelvic fracture, put a pelvic binder.
Okay.
And then retroperitoneal hematoma, we can monitor, sir. If it is stable or if it is of less amount, nothing to be done. It will be conservative. But if the hematoma is increasing or the patient is unstable hemodynamically, then we'll have to intervene and drain that hematoma, sir. And
See,
also pelvic fractures.
Yeah.
It will depend on the type of pelvic fractures that patient is having, sir. Usually, they divide it into 3 types, as far as I know, A, B, and C. With C involves that open book fracture, sir. If A or B, if it is, then can be managed conservatively with pelvic binder. If it is C, then it has to be operated, sir, for pelvic fractures.
Correct. But the thing is, what you said is right. Majority of the retroperitoneal hematomas post pelvic fractures are to be managed conservatively because the retroperitoneum itself offers tamponade. So majority of this bleeding will stop. So you just need to support the patient, ensure that you have an adequate amount of blood. You need to bring their temperature up because because of the blood loss, they would be hypothermic. So you need to put the patient with warm blankets and fluids which are warmed up, and blood transfusion again, and then correct the acidosis, correct the hypothermia, and then look at the coagulation profile. So make sure that the coagulation profile is seen, and then appropriate 1:1:1, that is packed blood cells, fresh frozen plasma, and what is the other one?
Platelets.
Platelets.
Correct. So you have to give that in the ratio of 1:1:1, so that all things are taken care of. and this is a dynamic process. So you have to constantly monitor these patients, make sure they are stable. Okay, so that is about the, and so as soon as now the patient is stabilized, you have looked at A, B, C, D, E. Then what do you do, Praveen?
So we have to do the secondary survey, sir.
So what a secondary survey?
Secondary survey includes from head to toe examination, sir.
Okay.
So, it includes examination of head, ears, periorbital injuries, facial bone injury, nose, mouth, neck injuries, and chest, abdomen, pelvis, both upper and lower extremities, and to check
And
the spine, sir.
and spine. So how do you check the spine?
Sir, we have to log roll the patient and to check, sir.
So before log rolling, what do you do? Again, make sure
First,
the
we have to make the cervical spine collar is
cervical
present or
spine
not,
is,
sir.
yeah, the cervical spine is stabilized. I think
Yes,
that's
sir.
very, very important. So don't put some stupid this one. It needs to be, proper cervical collar which supports the cervical spine.
Yes, sir.
So till you have stabilized the cervical spine, don't do log roll. Very
Yes.
important. So
Yes, sir.
ensure, because once if the patient becomes quadriplegic, then there is not much you can do. So you have to ensure, and anyway, you will have taken a X-ray. X-ray would give you an idea that whether there is any cervical spine injury or not. So take a proper X-ray to ensure you look at the cervical spine and
Yes,
chest, of course, and chest. Okay, so if the once the patient is stable, then you do the you can do a CT scan of the whatever areas that you need, that is usually chest and abdomen, and then also X-rays of the pelvis and long bones, whatever is needed. You can then do those things. Okay, now coming to this patient. So this patient has been shifted from another hospital, already 1.5 days old. Now
Yes.
the patient. So how now the patient is hemodynamically stable, just needing 2 ml of noradrenaline. Oxygenation is stable. So when do you operate on this patient? And what are the precautions you need to take? Sanya?
So depending on the scan that we get, a CT scan, once we get all the entire head to toe CT scan, like since this patient had head injury, chest and abdomen, so we'll get CT of the head, chest and abdomen to see what injuries the patient is having, sir. And
Okay.
if at all the patient is hemodynamically stable and having injuries which can be managed conservatively, we will monitor the patient serially with HbPCV and wait and see if the hemoperitoneum or hemoperitoneum is increasing.
Okay.
If there is
Now,
any, yes, sir.
the other thing is, Nikita, you didn't tell me what was the GCS of this patient.
So this patient GCS was 15, sir.
It is important for you to mention that, even though it is
Yes.
15, it is important. Is you mentioned a lot of figures, but you have to mention GCS first.
Okay, sir.
So GCS is 15. You
Yes,
said
sir.
he is conscious and alert, but other things are also there, no? EVM.
Yes, sir.
Okay. So GCS is 15. Now this patient has, according to the CT scan, fracture ribs on both sides with minimal hemopneumothorax. Then there is splenic injury, liver injury, pancreatic tail injury, and left kidney. The vessel is transected. Correct?
Yes, sir. Yes, sir.
Okay. So
Non-opacification, complete devascularization of left kidney, sir.
devascularization of the left kidney. Okay. Now, how will you manage this? I think we'll ask Sanket this. Sanket, what will you do? Will you
You
attend?
mentioned about some
In
AST
this
grade 5,
case,
all those grades.
Huh?
Grades ಗಳು ಹಾಕಿದ್ರಲ್ಲ, do they know the grades?
ಇದು this one trauma score ಅಲ್ವಾ ನೀವು ಕೇಳ್ತಿರೋದು?
AAST
Yes, sir.
grade 5 kidney, AAST grade 3 pancreas.
Ah,
Do you know all those grades?
Yes, sir.
okay, tell us then.
How do you
Nikita.
manage each grade? What is the grade? Is the time permits?
Yes, sir. Renal injury, there are 5 grades, sir. First one, it will start. One is the minimal, that is contusion. Second grade is hematoma, sir,
Ah,
which is or laceration, which is less than 1 centimeter. Third grade is laceration, which is greater than 1 centimeter. And fourth one will include any vascular injury, sir, with a contained hemorrhage. Fifth one is complete avulsion of renal hilum. In our case, it is the 5th grade, which is devascularized left kidney, sir.
okay. What about the pancreas and spleen? We'll
What
ask
is the
Ravi.
management of each
The
grade?
grades are same for all the solid organs, sir. Same,
Yeah.
the contusion, laceration, 1 centimeter and 1 centimeter each.
No,
Then
I think
the
for spleen it is different, no? The capsular hematoma, involving a particular thing or laceration of the spleen. I think their spleen is different, no?
yes, sir. Instead of
Yes, sir, it
laceration, it
is.
is subcapsular hematoma. Yes, sir.
Both.
Okay,
Sir,
Praveen, tell me about,
Sir,
is Vinod
sir.
back or not?
there is some suturing, it seems, sir, in the emergency.
No, but suturing can wait. You tell where he is gone. Is he gone there now?
Sir is doing it, sir. I just called. Yes.
Now call him up and tell him why is he doing suturing. Suturing is not that
Some
important.
pediatric case, it seems, sir. I think sir will join soon, sir.
Okay. Okay. Praveen, tell me about
Sir,
splenic classification
sir.
of splenic injury.
Yes, grade 1 laceration will be less than 1 centimeter and subcapsular hematoma will be less than 10% of the surface. In grade 2,
Correct.
laceration will be of 1 to 3 centimeters and subcapsular hematoma will be 10 to 50%. In
Correct.
grade 3, laceration greater than 3 centimeters and hematoma, subcapsular hematoma greater than 50%. In grade 4, there will be laceration to segmental or hilar vessels and with significant devascularization of about greater than 25% of spleen. In grade 5, there will be complete shattered spleen or hilar injury with complete devascularization.
Okay, good.
Usually, grade 1 and grade 2 will be, patient will be, vitals will be stable. So we'll be managing conservatively. In grade 3, based on patient condition, if patient is stable, then will be managed as similar to grade 1 and grade 2. If it is unstable, will be managed as grade 4 and grade 5 as exploratory laparotomy and splenectomy, sir.
You can
What is the
also
indication of partial splenectomy?
Sir, if the patient initially is in grade 1 and grade 2 and conservative management is not, he's not responding to conservative management, or if there is increasing in the injury, then we'll first try with angioembolization. If it did not work, then we'll be doing the splenic preservation surgery, sir.
see, the thing is, even grade 4 also you can conservatively manage. You can conserve the spleen, even though you operate on them, you can suture it, and as long as that suturing is done and the spleen appears to be, well perfused, you can conserve it. And there are even this Vicryl mesh net that is available, which you can place the spleen inside that, so that it will, even though the spleen is kind of shattered, you can still manage it conservatively as long as the vasculature is adequate or appropriate. You can even suture the vessel if that is, if it is torn. You can, suture it and see if the vascularity of the spleen is, the whole thing has, sort of shifted from doing splenectomy to splenic conservation as much as possible.
Yes.
Okay, so I think you, otherwise what you've said is correct. So you have usually first 3 grades, definitely, attempt conservative management, but make sure that you check their hemoglobin, vital signs, urine output, and hemoglobin PCV, and also repeated ultrasound scans to see if the hematoma is increasing or not. So all of these things will give you an idea how the patient is. And other thing is, when will you operate on patients with splenic trauma? Nikita?
If there is a internal bleedings or like if the HB is dropping and if the patient is hemodynamically unstable.
Correct. One.
Yes,
Other associated injuries. When you suspect
any
abdomen is
pancreatic injury.
distended, pancreatic injury, bowel injury. So
Yes.
when you have to explore for other reasons,
Hemoperitoneum.
large hematoperitoneum, possible bowel injury. In such cases, when you explore, you obviously have to have a look at the spleen also.
Yes, sir.
Now, this patient also had liver injury also. Is that correct?
No, sir. This patient did not have any liver injury, sir. There is one
Okay.
more case. He had
Ah.
liver injury. Yes.
Yeah, no, let us stick to this patient. So what was the
Okay, sir.
indication? What was the indication for surgery, Samia, in this patient?
The kidney on the left side showed complete devascularization. So it was grade 5 renal injury.
Okay.
And
then?
pancreatic injury was also with the distal transection of pancreas. So there's injury to the distal end of pancreas.
Okay.
That like pancreatic complete transection was there.
Okay. And then splenic
While
injury
the
also.
splenic
And then
contusion is
splenic.
grade 2, sir, so can be managed conservatively, but other two are indications for surgery.
Okay. So what did you do?
Sir, I think left side, left nephrectomy was done, and
Who went for surgery?
Why you are telling? I think,
Sanket. No, I was not there for this
I
case.
was there, sir. Sanket sir was there.
madam, whether
Okay.
you went or not, you should know what has happened before presenting.
Yes, sir, I know.
Then
Sanket, tell me what was done.
Yes, sir. So there on exploration, sir, left side nephrectomy was done, sir. Since there was left side kidney was pale and soft, and the artery was blocked due to clots, sir. So
Okay.
left nephrectomy was done, followed by there was complete transection of distal third of pancreas, sir. So that distal third of pancreas was resected, and then closure of proximal end of pancreas was done. There was no active bleeding. There was no active bleeding as such. Around 300 to 400 ml of hemoperitoneum was noted, but there was no active ooze as such. And the spleen, examined part of spleen, there was just a hematoma in the superior pole of spleen. So decision was made not to intervene for that.
Okay. Right now, Sanket, when you open the abdomen,
yes, sir.
You would usually have an idea because you would have done a CT scan. Let us say you open an abdomen when the patient is very unstable. Okay. You have not had an opportunity to do a CT scan. Patient is a very unstable. What will you do in that situation?
So in that, initially, if a patient is unstable and first we have to find for any active bleeding, sir, then we have to stop the.
That is, just, what will you do? I'm asking you a practical question. See, other thing all of you forgot to mention is all trauma, when the patient comes to casualty, you have to give them 1 gram of tranexamic acid. It is been proven. It has been proven beyond doubt, especially in trauma patients, that it makes a huge difference. It brings down the mortality by anywhere up to 30%, which is very significant. So you have to definitely give them tranexamic acid. Of course, you then have to, have the blood ready in the proportion of 1:1:1. And then, see, the main thing is what you do in a situation where you don't know, because the patient is unstable and the abdomen is very distended, there is bleeding, patient is hemodynamically unstable, and you know there is massive bleed inside, what you have to do is quickly do a full laparotomy, quickly evacuate the hematoma and pack all the quadrants. Okay. So this is what I wanted
Okay.
you to say. So you have to pack the quadrants and then get the anesthetist to get some control of the patient. So don't do anything till such time the anesthetist tells you that I'm okay, that they have now, because two things will happen. As you said rightly, there will be bleeding. Second thing is the tamponade will be lost. So when the tamponade is lost, there will be significant hypotension. So you don't want to do a perfect job and lose the patient. So you have to pack, get the sisters to have even more, if there are large abdominal packs, right? Otherwise, even nowadays, the problem is previously we used to get these, these drapes. So you wet the drapes and you can use it for packing. But unfortunately, we are now using these, the sister to have at least about 10 or 15 packs, not just mops, but packs, abdominal packs, which are larger, and then pack all the 4 quadrants. After sucking out the blood, you have 2 suckers. So suck the blood out quickly, pack 4 quadrants, and then if you want even, sort of close the abdomen, in the sense use Alice or something to just, close the abdomen and allow the anesthetist to get some control over the patient's hemodynamics. So they may give blood, they may give fluid and whatever, warm the patient up and all of those things. And then what you do is, one by one, you remove the packs from each quadrant and find out where exactly the bleeding is happening. You may get an idea, but so what you do is, one by one, you remove the packs. And if, for example, the lower quadrant, there is no bleeding, you can, forget about that. Then take the other lower quadrant and then go to the upper quadrants so that you know exactly where the bleeding is happening and then deal with it. Sometimes, if at all it is retrocaval liver injury, the bleeding can usually be not controlled, or you may want a liver surgeon or somebody to come, because most of us would not know how to deal with hepatic caval injuries or the hepatic veins if they are torn off from the inferior vena cava. So what you have to do is to pack the liver and then wait for a transplant surgeon to come and give you a hand to control the bleeding from there. If you are well versed, then you can obviously mobilize the liver, identify whether it is the right hepatic vein, middle hepatic or left hepatic vein, or the retrohepatic cava. So then you will have to repair that. So that needs a lot of technical expertise. So many times, if you are in a situation where you can't get a transplant surgeon or a liver surgeon, all you have to do is to pack this area nicely, use multiple packs and pack the liver completely. And usually that will stop the bleeding. And then again, you then deal with the spleen, deal with the pancreas, deal with any other injuries. And then sometimes don't do what is definitive surgery. If there is bowel injury, you just resect the segment which is devascularized or ischemic and ligate the vessels. Don't try to do anastomosis. What is this called, Nikita?
Damage control surgery, sir.
Okay, so basically you just have to stop the bleeding, maybe warm fluid into the abdomen, wash it thoroughly, and if there is bowel that is ischemic, resect that segment, staple it off, and pack the liver. If you can control, if it is surface liver injury, you can suture it. You get special plug-jetted sutures, catgut sutures, which you can use to control the bleeding. Otherwise, pack the liver. Spleen, you deal with it appropriately. Grade 1, 2, 3, you can conserve the spleen. Ensure that you pack that area and ensure the bleeding has stopped. And look at all other injuries, kidney, for example, and bowel, pancreas, all of them, deal with them. Then leave the abdomen open. You can Usually they would, you can just put what is called Bagota bag. You don't have a Bagota bag, you can use the IV fluid bag, 1 liter bag. Just place it in front and then, just put a few staples to the skin and come out. In addition, because if there is pneumothorax in this patient, you will have to put intercostal tube because the patient is now being positive pressure ventilation, so they will develop pneumothorax if you don't do that. So if it is necessary, put bilateral intercostal tubes. If you know definitively that is one side, put intercostal tube in the appropriate side. Then you may have to get your orthopedic colleagues, if there are long bone fractures, to put external fixators. Don't try to fix the fractures at this instance, and then shift the patient to ICU. What are the three, Praveen, what are the three things you need to look after in the ICU in these patients? What is the killer triad or lethal triad?
Sir,
Praveen?
hypotension. Sir, yes, sir. Hypotension.
Not hypotension.
Hypothermia, coagulopathy, and acidosis.
Correct. Praveen, what is this, man? So, hypothermia, coagulopathy, and acidosis. These are the three things you need to take care of. So, correct the acidosis. Usually, correcting the acidosis means what, Praveen?
Sir, we have to check for the carbon dioxide entry and out, sir. If patient is in.
No, man. No. See, Nikita, can you elaborate? What does correction of acidosis entail?
Sir, if it is respiratory acidosis, we can correct it by intubation and supplementing oxygen, sir. But if it is metabolic acidosis, we will transfuse the bicarbonates.
No, don't, usually not necessary. Only that is when do you actually, they say nowadays, you don't transfuse bicarbonate at all. But when is it necessary to transfuse bicarbonate or infuse it's not transfusion, it's infusion. Sanya or Sanket? We know when you are back, you have to let us know.
Hello, sir.
What was the need for you to start suturing in the class time, man?
Sir, active bleeding is sir.
Okay, right. How do you manage acidosis? Correction of acidosis.
Sir, if it is because of active blood loss which is leading to acidosis, then you have to give blood correction should be done, sir.
Correct. Good.
And if it is less than 7 or patient is unstable, then we can give the bicarbonates and correct it, sir.
See, the thing, what you have to say is, I think Nikita started it off correctly, but see, majority of these things will be combination, Nikita. It will not be pure respiratory acidosis or pure metabolic acidosis. It will be a combination of both because it's a polytrauma, right?
Yes, sir.
So it's a combination of fracture ribs, inability to breathe, pain, then hypotension because of blood loss, then all these things. So it's a combination. So your answer should be ventilate the patient and then give them adequate oxygen. Okay. So that is one. Second thing is to correct the hemodynamic instability by giving them fluids and warm fluids and blood. And if correct the coagulopathy by giving them fresh frozen plasma, and if it is available, factor 7, factor 8 transfusion. Okay, and platelets if necessary. So, and then, all these combination of everything, usually once the patient becomes hemodynamically stable, acidosis corrects itself naturally. Sometimes, if the patient has already gone into acute kidney injury, then you will have to consider dialyzing these people. Initially, maybe give them furosemide infusion and see if there is some urine output. If there is no urine output, then you will have to dialyze them. That will correct the acidosis. Correct? Do you agree or not?
Yes, sir.
And infuse, improve the temperature of the patient, put the, you can use warm blankets, all of those things. And infuse warm fluids which are warmed up in the fluid warmers, and then give them blood as and when required. So by doing all of these things, you will correct both the acidosis and you will correct the coagulopathy, and then you correct the hypothermia. So basically, when will you re-operate on these patients?
When this hypothermia, acidosis, and coagulopathy is corrected, then we'll take it.
Yeah, correct. But generally, what is the time scale we are looking at?
After 48 hours, sir.
Yeah, 36 to 48 hours. Generally, it takes about 1.5 to 2 days for it to all correct. Shrikant, anything to add so far?
No, exhausted. Very good.
So, basically, the principle of damage control surgery is first, control the bleeding, remove the dead and debris, and dead tissue and debris. For example, if there is long bone fracture with lot of muscle injury which is denatured and sort of dead muscle, you will have to debride that, because that will continue to fuel your sepsis, your acidosis, and everything. So you have to remove all the dead tissue. That is, for example, that also applies to the bowel. So if there is bowel injury and the bowel is ischemic, you will have to remove that segment of the bowel. You will have to remove. You may have to do amputation if the leg is leg is ischemic. So all of these things. And then other thing is, if there is fracture, you will have to stabilize that fracture by external fixators. Don't try to do primary repair. You put external fixators for pelvic fractures, as Sanya said, pelvic stabilizers. Only the type 3 pelvic fractures need to be repaired. And again, that can be repaired once the patient is more stable. So then you have to take care of the thoracic injuries, thoracic vascular injuries, sometimes and pericardium. You may have you will have to cardiac tamponade. You need to take care of that. Sometimes there will be injury to the great vessels. So all of these things take precedence. So once the patient is, and then head injuries, if there is subdural or intracerebral hematomas, you will have to evacuate that. So all of these things take precedence. So do all that is necessary, only that is necessary, and come out, and then shift the patient to ICU and do all the things that we just described, which will stabilize the patient, correct the acidosis, correct the hypothermia, correct the coagulopathy. So once all of that is done, then you can take the patient back to the OT, and then you do definitive surgery, that is anastomosis, and for orthopedic cases, fix the fractures and everything. So this is usually how you do this. Now, what is massive blood transfusion, and how do you deal with it? Nikita?
Yes, sir. Massive blood transfusion protocol is if you use greater than 10 units of blood, sir. And we initially inform the blood bank that we are going to initiate the protocol. We need continuous supply, and they need to be transfused in the 1:1:1 ratio, as you have mentioned previously, sir. One PRBC to 1 platelet to 1 FFP.
Okay.
Yes, sir.
And then what
in the
are the
meanwhile,
problems?
Yes, sir. There could be decreased calcium, so calcium gluconate should also be given in between. And to monitor for reactions in coagulopathy, sir.
Coagulopathy, that is one. What is TRALI?
Transfusion related acute lung injury, sir. Acute lung.
Correct. Transfusion related acute lung injury. Again, that needs to be, you need to bear that in mind. So, and
Yes,
so monitor these patients. and you need to check their, coagulation, both APTT and PT INR. What does PT suggest to you and what does APTT suggest to you? Sanket,
So I don't know exactly, but
Tanya,
Hello, sir.
what does APTT signify to you and PT INR?
I'm not sure, sir.
Anybody in the class?
Sir, external pathway is by PT, sir, and APTT is by internal pathway or common pathway.
Okay. So you need to know both, whether extrinsic and intrinsic and the common pathway. So where is the common pathway? Where do they link common pathway?
Sir, from factor 10 it will start, sir.
Okay, factor 10 to 10A.
Yes, sir.
Okay. So basically you need to monitor both apart from the platelet count, because when there is disseminated intravascular coagulation, you will obviously the platelet count will drop. So in those situations, what do you do? Paradoxically, anybody?
No, sir.
We can transfuse any single donor platelets, sir, or FFPs.
All those things you
Will it
do,
help?
but you also give something else. That's why I said paradoxically. Homework for you. All of you.
Antiplatelets, sir.
tranexamic.
No, tranexamic acid you give anyway, which you have to
Antiplatelet-
repeat after 8 hours.
Antiplatelets, sir.
Not antiplatelets.
Anticoagulants.
What anticoagulant? You have to use heparin.
Low
So
molecular
just
weight.
read up about this. Okay.
Yes.
You can use heparin for these situations. So anyway, now this patient has been operated. You have managed to conserve the spleen. You have done a left nephrectomy, and then you have, how is describe the post-operative period of this patient?
Sir,
Nikita.
post-operatively, he was extubated after 3 days, sir.
What are the problems you
ICDs were-
expect in him? What are the problems you expect in him?
The simple ones would be like paralytic ileus, sir, and secondary reactionary hemorrhage.
Reactionary hemorrhage, yes. Bleeding.
And as there is only one kidney, there could be any acute kidney injury or decreased urine output.
Unless the patient is hypotensive
Yes, sir.
and has been hypotensive for a long time, then with loss of one kidney, you may be right. The other kidney may go into acute tubular necrosis because of hypotension. Otherwise, one kidney is sufficient usually. So if the
Yes.
patient's blood pressure and things have been okay and he was passing urine reasonably, it is reasonable to expect that now that he is in your hands and you have now taken care of the bleeding and you've dealt with all the problems, the kidney should not be an issue. But you are right. It may
Yes.
be that the patient may go into sudden bleeding and he may have acute tubular necrosis and acute kidney injury. Yes, that's one. Bleeding is another. You have done pancreatic, ductal ligation. What can happen?
Leak, pancreatic leak.
Pancreatic leak, but also, when there is pancreatic injury and you handle the pancreas, what can happen?
Pancreatitis.
You can have traumatic pancreatitis, right? So traumatic pancreatitis
Yes,
can be there. So that can be quite severe. So you have to watch for that. And you have handled the left side, around the stomach area and things. So what can happen there?
Perforation.
Especially
Gastric.
not perforation.
Dilatation.
Gastric vessels injuries.
Dilatation.
Acute gastric dilatation. So Many times patients complain of sudden left-sided upper abdominal discomfort and pain. And when you see the abdomen is tympanic, so you can, if you pass a Ryle's tube and decompress the stomach, it may take some time, but it will recover. So that is another thing that you need to be worried about. And everything that has happened under the diaphragm, what can happen above the diaphragm?
Reactive pleural effusion,
Pleural
sir.
effusion.
Reactive pleural effusion, atelectasis, left-sided plate atelectasis,
Yes.
pneumonia, and pleural effusion. All these things can happen. So you need to be aware of all the post-operative complications, and then of course wound infection, all these things. So, and collection, intra-abdominal collections can happen, and that can secondarily get infected, which happened in this patient or not.
It did happen in this patient. Looks like
There is a
Yeah.
collection, sir, but no infection.
There was infection.
it was pus, sir, but sterile pus as of as of
Drain,
now.
Just show me.
drain was not kept. Huh?
Drain was there, sir.
Yes.
There was drain output decreased, but little distant from that drain, there was some collection, sir, approximately 100 ml.
See that you see till
That
you
means
may
there is
not
blockage of the drain.
No, sir, we milked it. Drain was clear.
Working.
Drain was not into that collecting zone, sir. To separate collections.
See, the thing is, it's difficult to say sterile pus because you have been on heavy duty antibiotics. So it would
Yes.
be, so the organism may not grow, but it will be, pus. So you can't call it sterile pus. It is, infection. So infection of the collected fluid. So that is another complication that can happen. As you said, ileus. So, and how do you deal with the nutrition of this patient?
We'll initiate the RT feeds once the patient is bowl sounds have present and they started passing flatus. Along with that, we also have started TPN as early as possible on the day 1, sir. We're expecting him to be nil per oral for longer duration. So yes.
No, but if if the bowel is, if bowel can be used. So what is the duration of, is there any small bowel ileus usually?
He had ileus in the immediate post-op, sir.
So in that situation, you may want to start TPN because I think maybe for the past 3 days, he was not on anything. So you may want to give him TPN. And
Yes.
as soon as you can, the abdominal distension comes down, you can start using, because the small bowel ileus is practically absent. It is gastric and colonic ileus. That is, gastric usually recovers in 24 hours, colonic ileus in about 2 to 3 days. So sometimes these things can be prolonged due to various factors, patient being unstable, hypotension, and inotropic support, or sepsis, or electrolyte imbalances. All of these things can prolong the ileus, but otherwise the general rule of thumb is small bowel ileus virtually practically after 6 hours, corrects itself. Gastric ileus 24 hours to 36 hours, and colonic ileus is between the 48 to 72 hours. So you can start feeding them as soon as possible, even clear fluids, so that the advantages will be the mucosal blood flow is, not lost. So translocation of bacteria and things like that will not happen. And then you are using the gut so that the nutrition is much more natural and balanced. Then TPN, there should be a transition between TPN and enteral nutrition, so that you can't withdraw TPN suddenly, because there can be major electrolyte and ionic
Right.
fluxes that can happen. So you have to be careful about that.
Yes, sir.
Right. I think one patient is sufficient. Any questions from anybody?
What is the outcome? What happened to the patient?
Sir, right now he is not on any inotropes, sir. Till yesterday he was tolerating RT feeds and he was passing stools. But since today morning, there is some abdominal distension.
That's okay.
Otherwise, hemodynamically, he is stable, sir. He
Very
had a high heart rate and respiratory rate, which has come down now. Yes, sir.
Okay. So, Sanya, Sanket, any questions? Students, any questions?
No,
No,
sir.
sir.
No questions.
Yes, sir.
See, the thing is, I've gone through the latest, guidelines and recommendations as far as polytrauma is concerned. I think there has not been much change in terms of it is the same ATLS protocol, ABCDE. Again, ABCDE is, A is along with cervical spine, and C is along with control of hemorrhage. And then the secondary survey and the trauma scores are important. And then there is something called ALE, which I think you need to look into. And so I think the homework for you guys would be to put up the trauma score and the significance of the trauma score. Okay?
Yes.
Who's going to do
Yes, sir.
it? Who's going to do that? All of you?
Yeah, yeah,
It's
yes.
yes, sir. Yes.
All of you read up about it and put it up so that what is the significance? The one class for trauma is not sufficient. So the importance is for us to discuss about this particular patient. So what I did was to try and give you an overall picture of what, how to manage a polytrauma, especially from the site of the injury till the operating table and the post-operative problems and complications, and then management in the casualty, management in the OT. I think you can discuss. I think broadly, I told you about how to manage the trauma in terms of the control of hemorrhage and everything. But this you should know, because many times if in your peripheral place, let us say, it is not see nowadays all places are getting motorways and the highways. So when you wherever you are likely to get a patient who has had a major road traffic accident and come to your hospital. So you should be able to manage them. So even if you then subsequently transfer them to another unit, you should make sure you transfer them in a more stable state from how they came to you. So I think we've discussed all the, sort of management of trauma. I think if you can't do anything, at least pack the patient. All the 4 quadrants you need to pack properly, close the abdomen, and then send them across to somewhere else. So I think this much you should know, and immobilize the fracture so that there is no bleeding. Because what is the amount of blood in the thigh when there is fractured femur, man? Pravi?
Sir, around 1 to 1.5 liters, sir.
That is a bit too much. 800 to 1 liter. 800 ml to 1 liter for a fracture of the femur. And fracture of the leg, about 600 to 800 ml. Okay, so you need to know all these things. Pelvic fracture, I think we spoke briefly. Again, all of these are separate classes on their own. This was just a ward round as to how to manage trauma. Okay, so this is not a class on trauma, but it's a ward round. So basically, it is all practical questions as to how you deal with individual circumstances. So if there are no other questions, shall we stop here? No answer.
Yes,
Yes, sir.
yes, sir.
Yes.
Yes, sir.
Yes, sir.
So no questions or clarifications? So
No,
that
sir.
homework is the trauma score, ALE, and also the use of heparin in patients with disseminated intravascular coagulation. Okay?
Yes, sir.
Okay. Good night, everybody.
Thank you, sir.
Good night, sir.
Shrikant, thank you, Pa.
I should thank you. Thank you very much. Good presentation. Good night.
Good night,
Good
sir.
night.